Hello and welcome to part 4 of clinical cases for the musculoskeletal system. Today we're going to be taking a look at some more common abnormalities including Cauda equina syndrome, lumbar disc herniation, osteomyelitis, the different types of spondyloarthropathies, congenital defects, SCFE and compartment syndrome. So let's start by taking a look at Cauda equina syndrome. So this is compression of nerve roots distal to L1. So in order to understand this condition, you need to know what the normal Cauda equina is. So the Cauda equina is found distal to L1 vertebra. In other words, where the spinal cord ends, the Cauda equina begins, and it carries on all the way to the coccyx, and it's made up of 11 pairs of spinal nerves. Any damage or compression here causes Cauda equina syndrome, and the more caudal it is, in other words towards the bottom of the patient, the less motor or sensory deficit they experience. So the higher up the lesion or the compression, the more symptoms or the more motor sensory deficit the patient's going to experience. It tends to be the lower motor neurons that are affected, and larger fibres that carry things like motor impulses, proprioception, like touch, are less susceptible than those smaller fibres that carry things like pain and parasympathetic innervation. The red flags for Cauda equina syndrome include urinary retention, so 75% of patients who have Cauda equina syndrome will also have urinary retention, perianal sensation loss, reduced anal tone, bilateral leg pain and erectile dysfunction in men are also common red flags for Cauda equina syndrome. So the causes behind Cauda equina syndrome, the most common is lumbar disc herniation, which we're going to discuss in the next slide, but also trauma is a common cause. Cauda equina syndrome can be broken down into 3 different types, so early, incomplete, and retention. So this is Cauda equina syndrome early, and these patients experience bilateral leg pain, perianal sensation loss, lower limb motor power abnormalities, but incomplete Cauda equina syndrome experience all of the same plus reduced bladder and bowel sphincter function. And then finally the last group, the retaining group, these have the inability to pass urine or control the bowel. So symptoms we've already discussed above, and onset of symptoms can be rapid or gradual depending on the cause of Cauda equina syndrome, and management again depends on the type. So early we would monitor the patient and do an MRI scan. Incomplete we would do an urgent operative decompression within 24 hours, and for retaining patients we'd also want to do an urgent decompression. Next we have lumbar disc herniation. So this is one of the most frequently surgically treated disorders of the spine, but not all patients with this disc herniation will experience pain. Sometimes they will experience pain, and in this case it's normally worse in the leg than it is in the lower back, and this is commonly referred to as sciatica. So this is because the sciatic nerve travels down the posterior aspect of the leg, and pain is usually described as sharp or shearing, electric, radiation or piercing. So really sharp pain here, no dull ache. So symptoms can be dependent upon what level the disc hernia is at as well. So what happens here, the disc protrusions most frequently occur at the posterior lateral margin of the disc. So this is because the annular fibres are weakest at this point, and there's less support from the posterior longitudinal ligament. So the posterior longitudinal ligament runs down, and this means that centrally the disc protrusions are often limited by the fibres, but actually in a posterior lateral margin they are quite frequent. There are different types of herniation which can be linked up to the pictures below. So we can have a nuclear herniation, here where the nucleus ruptures through the innermost fibres of the annulus fibrosus. A disc protrusion takes it one step further, where the ruptured nucleus distorts the outermost fibres of the annulus. Then we can have a nuclear extrusion, where we get a bit of nuclear material leak out to the surrounding space but doesn't go anywhere. And then we have a sequestered nucleus, where this parted nuclear substance is no longer attached to the material remaining inside the disc, and it can float around the spinal cord and become totally remote. The mainstay of management tends to be rests, non-steroidal anti-inflammatories, physical therapy, and epidural steroid injections, but in a minority of patients they may experience more severe pain and may need surgical treatment, so this is a microdiscectomy. Next we have osteomyelitis. So this is an infection within a bone, and the infection can arise from anywhere else in the body, so travelling in the bloodstream, travelling from nearby tissues to the bone, if it's exposed to bacteria during, for example, an injury. Now in children, osteomyelitis commonly affects the humerus and the femur, so the long bones of the arm and the leg, and often targets those growth plates. Adults are more likely to develop osteomyelitis, however, in the vertebra. So people who have diabetes as well, they can develop osteomyelitis, but they commonly develop it in their feet due to having diabetic foot ulcers. So sometimes osteomyelitis can be asymptomatic, but in many cases it'll cause fever or chills, irritability or lethargy, pain in the area of the infection, as well as those classic signs of inflammation and infection, so swelling, warmth, redness over the area of where it is infected. So the majority of cases of osteomyelitis are caused by Staphylococcus bacteria, so Staph aureus for example, and the method of infection, as we've already said, can be via the bloodstream, so from another infection such as a pneumonia or UTI, or from a nearby tissue. So infection can also directly target the bone, for example if it becomes exposed during injury, so for example in an open fracture, the bone may become exposed to bacteria in the environment. This can contaminate the bone and cause an infection. So bearing this in mind, we can relate this to the risk factors. So for example, a recent injury or orthopedic surgery will give infection a route to enter the bone. Circulation disorders such as impairment of the immune response to infection can also cause osteomyelitis and spread from distal sites. IV lines and catheters are also a risk factor because again it gives infection a route to enter the body. And immunodeficiency, so suppression of the immune system, so for example in chemotherapy, these patients will have less of a chance of fighting off the infection before it spreads, say for example via the bloodstream to the bone. Next we have spondyloarthritis, which is an umbrella term for inflammatory diseases involving the joints and the epiphyses. So the epiphyses are the sites where the ligaments and tendons are attached to bones. So spondyloarthritis can be divided into axial or peripheral. So axial spondyloarthritis include ankylosing spondylitis and axial spondyloarthropathy. And peripheral forms include psoriatic arthritis, reactive arthritis, and enteropathic arthritis as well. So the causes behind spondyloarthritis have a strong link to HLA-B27. Now HLA, so human leukocytic antigens, are most commonly found on white blood cells, and this is exactly the case for HLA-B27. It's found on the surface of white blood cells and it is a protein. Now if we think about the normal role of HLAs, these protect our body from harm. However, HLA-B27 is a specific type of protein that contributes to immune system dysfunction. And as a result, this leaves us open and defenseless to autoimmune insults. In other words, the body starts to attack those otherwise normally healthy cells. So just to think about them all in a little bit more detail, if you think about the peripheral forms of spondyloarthropathies first, psoriatic arthritis is inflammation in and around the joint, in usually those patients who already have psoriasis. And one of the distinguishing points from rheumatoid arthritis is that psoriatic arthritis usually is mono or oligoarticular. In other words, it affects fewer joints than rheumatoid arthritis, but it still causes that characteristic swollen joint and pain. Now reactive arthritis, this is again the heat, pain, swelling of large, medium joints that develop shortly after an infection. So this infection tends to be from the genitals, so for example chlamydia, or from the bowel, so for example Campylobacter or Salmonella. Enteropathic arthritis is a group of rheumatological conditions that share a link to GI pathology, so tends to be inflammatory bowel disease that these inflammatory spondyloarthropathies are linked to. Enteropathic arthritis also has a very strong link to HLA-B27, and approximately 80% of cases are linked, and it's believed to be due to an abnormal permeability of the bowel to bacterial antigens, which then locate in articular tissues and lead to an inflammatory response. So ankylosing spondylitis is a form of axial spondyloarthropathy, and it's a chronic systemic rheumatic condition where the spine and other areas of the body become inflamed. It commonly first develops in teenagers and young adults, and it's approximately 3 times more common in men than it is in women. The symptoms are often slowly developing and come and go over time. It tends to occur with back pain and stiffness, and this is usually described as a chronic and dull pain. There's also said to be pain and swelling in other joints of the body caused by arthritis or enthesitis, and extreme fatigue as well. There tends to be with disease progression, loss of spinal mobility, loss of range of movement, and chest expansion. So the cause behind ankylosing spondylitis is unknown, but again there's believed to be a massive strong genetic link with HLA-B27, and around 90% of cases here do have a link to this HLA-B27, so leaving us susceptible to autoimmune attack. With regards to diagnosis, the clinical features are really important, what we've just discussed. They tend to have a good response to NSAIDs in these patients. Radiographic features are also really important, so you tend to see changes in the sacroiliac joints, pseudo-widening of the joint space, squaring of the vertebra, with spine ossification as well. If you do investigations, naturally this is a inflammatory process, so you'll see raised CRP, ESR, so inflammatory markers, and you'll see a positive test for HLA-B27, as we've said, in around 90% of cases. Schober's test can also be useful to assess the mobility and range of movement of the spine. And treatment for these patients tend to be focused on NSAIDs, DMARDs, so pain relief and stopping the progression of the condition. So NSAIDs, an example would be ibuprofen, and an example of a DMARD, so disease modifying, these are, an example here is methotrexate. So surgery in severe cases as well can help with correction in those with flexion deformities, so this is more of an advanced case of ankylosing spondylitis. A brief word on congenital limb defects. So these tend to be due to genetic abnormalities, growth restrictions, mechanical forces, exposure to chemicals and viruses by the mother, and the diagnosis is normally made at birth. So it tends to be either a complete absence of the limb or a failure of a portion of the limb to separate. We can also see congenital defects in things like duplication, where there's extra digits, or overgrowth or undergrowth of a limb. A few examples here, so polydactyly, where we have more than the normal number of fingers or toes, syndactyly, so the fingers or toes are partially joined together, and then limb deficiencies, the prevalence is around 7.9 in 10,000 live births, and radial ray deficiency is the most common upper limb deficiency, and hyperplasia of the fibula is the most common lower limb deficiency. Next we have SCFE, so slipped capital femoral epiphysis, and this is the most common hip disorder of adolescent children. So it occurs when weakness in the proximal femoral growth plate allows displacement of the capital femoral epiphysis. So to put that in simpler terms, the ball at the head of the femur slips off of the neck of the bone in a backward direction, and this causes pain, stiffness and instability in the affected hip. This can be seen in this joint here, so here you've got your femur, your neck and your head attaching into the acetabellum of the hip here, and so you can see that there's slight displacement here of the ball of the head of the femur slips off of the neck, okay? And so SCFE actually is a mesonomy because it's actually the metaphysis that displaces anteriorly and causes and superiorly, leading to this slipped state. So the causes behind this, it tends to be a chronic condition as opposed to an acute condition, so weakness at the growth plate, stress on the growth plate due to obesity, endocrine disorders, and a period of rapid growth is usually responsible for this SCFE. There are two types. You can have stable SCFE, so this is where the patient's still able to weight bear on the affected hip, whether it be with or without crutches, and unstable SCFE, so this is more severe, and this patient cannot walk or weight bear on the hip. So epidemiology of this, as we said, it most commonly occurs in adolescence, so between the ages of 10 and 16. The incidence is around 10 in 100,000 children per year, so quite high incidence, and the left hip is affected much more commonly than the right hand side. So as we said, presentation can be chronic or acute, so chronic presentation is more common, with intermittent mild pain, weakness 3 or plus weeks, and thigh atrophy and limping. Or it can be acute as well, so severe pain, alterations to the gait, limited range of movement of the hip, and external rotation of the leg. The investigations in these patients, you'd want to do a physical examination, but X-ray tends to be diagnostic, and it's important to look at an X-ray from an AP and a lateral view in order to be able to see this. Sometimes on the AP view it's not always that obvious. So the management here, the goal of the treatment is to prevent the mildly displaced femoral head from slipping any further out of position, but surgery tends to be the mainstay of treatment, and in stable SCFE this is an in situ fixation, and in unstable SCFE this is an open reduction. Finally, for this video, we take a look at compartment syndrome. So this is a very generalized term, and compartment syndrome can occur in several places across the body. It's a painful condition that occurs when pressure within the muscles build up to dangerous levels. So if you think about our normal anatomy here, so compartments are groupings of muscles, nerves and blood vessels in the arms and legs, and covering these tissues is a tough membrane called a fascia. And the tough membrane is really important because it keeps the tissues in place, but it doesn't stretch or expand very easily. And therefore, when we get swelling or bleeding within a compartment, the fascia does not stretch, and this causes increased pressure on the capillaries, nerves and muscles in the compartment. As a result, these patients tend to present with pain which is worse on movement, tingling or burning sensations, and numbness is a late sign indicating permanent damage. It's important also to differentiate between acute causes, so things like fractures, post-operative conditions, crush injuries, tight bandages, anabolic steroids, versus chronic. So this tends to be due to repetitive movements and is common in athletes. And whether it's acute or chronic determines how you'd manage the condition. So an acute compartment syndrome is a surgical emergency and you want to produce a fasciotomy ASAP. And if it's a chronic compartment syndrome, you can try conservative management first, and if that then doesn't work, you can try surgical options afterwards. That's everything for this video and the end of the musculoskeletal system. If you do have any questions, please let me know, and any feedback is always greatly appreciated. Thank you very much for listening.